So let's see the classification. The bullous disorders are of two types, one having epidermal blister and second having a subepidermal blister. The epidermal blister diseases are Pemphigus vulgaris and Pemphigus foliaceous. In Pemphigus vulgaris, there is a suprabasal acantholysis. So there is a gap between basal layer and the rest epithelium. In the Pemphigus foliaceous, there is a subcorneal acantholysis. So there is a gap between corneal layer and the rest epithelial layers. So let's see the illustration. In the Pemphigus vulgaris, there is a gap between basal layer and the rest epithelial keratinocytes. So first is basement membrane, then basal layer, spinosum layer, granular layer and corneal layer. These all are the layers of the skin. So in vulgaris, there is a gap between basal layer and all rest epithelial layers. In the Pemphigus foliaceous, there is a subcorneal blister. So there is a gap between corneal layer and remaining epithelial layers. So in the Pemphigus foliaceous, this is the gap. Now let's learn one by one. First is Pemphigus vulgaris. It affects mucous membrane plus skin. Suprabasal acantholysis is seen. Autoantibodies are anti-desmoglein 1 and 3 immunoglobulin antibodies. The disease usually begins with mucosal ulceration when skin is involved later. Most common sites are mucous membrane, upper and central chest, back, face, scalp and flexures. Associated HLAs are DRB1 and HLA-DQB1. Pemphigus foliaceous. In this disease, only skin is involved. The mucous membrane is spared. There is a subcorneal acantholysis. And here autoantibodies are anti-desmoglein 1 immunoglobulin antibodies. There is an endemic Pemphigus foliaceous common in Tunisia and Brazil, which is called Fogo selvagem. Sometimes the Pemphigus is drug induced and which is associated with penicillamine and captopril. HLAs are associated with Pemphigus foliaceous are HLA-DR4, DR14, DR1. Symptoms include burning, pruritus and pain. There are scattered and crusted lesions involving seborrheic areas such as scalp and face. The Nikolsky sign is present. Disease may stay localized for a year or it may rapidly progress to generalized involvement resulting in exfoliative erythroderma. It is associated with high morbidity, mortality and potential life-threatening complications. The septicemia is a leading cause of death in Pemphigus. The diagnosis is done by H&E, direct immunofluorescence, indirect immunofluorescence and ELISA. The direct immunofluorescence is always performed on the normal appearing perilesional skin. On H&E, if the blister roof is missing, the basal keratinocytes may separate from one another laterally, which resembles a row of tombstone in Pemphigus vulgaris. DIF reveals intercellular immunoglobulin or C3 deposition in the epidermis, which shows a chicken wire fence or honeycomb fluorescence pattern. In Pemphigus foliaceous, if blister roof is missing, then remaining epidermis looks relatively normal. So the findings can be non-specific. The bulla contain fibril neutrophils, scattered acantholytic keratinocytes, and these keratotic cells in the granular layer of older lesions distinguish Pemphigus foliaceous from Pemphigus vulgaris. Treatment. The first line treatment of mild Pemphigus is systemic corticosteroids, which take several weeks to achieve a response. Second line treatment is in the combination of corticosteroids include adding either azathioprine or mycophenolate mofetil. Anti-CD20 monoclonal antibodies such as rituximab and ofatumumab have also been used in conjugation with corticosteroids for the first line treatment in moderate to severe Pemphigus. Third line treatment includes intravenous immunoglobulin, cyclophosphamide, dapsone, immunoadsorption and methotrexate.